going with our time that's just for you and these physician experts. So our panel will come on up. This is actually not a question, so I won't give it to you.
Okay, so we have some really expert people sitting in the audience, and anybody can jump in if they have better answers. So here's one, Mark, for you specifically. Okay, Mike, I'll read one. We'll just keep reading questions. Why is it so hard to get the hospitals and ER to understand this and help people with HAE? The medications are great, but the ERs are horrible. Well, first of all, Dr. Christensen and my daughter is an ER doctor, so I think they're terrific. But they aren't really at the top of their game for HAE. I think it's a really tough problem. They think differently. They don't really have the time to study this disease. And all I would say is the goal of many of us is to keep you out of the ED. What we'd really love to do is have you get treated at home or be on successful prophylaxis. And I think that's the best solution to that problem.
Okay. This question is getting at some of the issues that we were looking at in terms of quality of life, mainly people's appearance. During a swelling, how can we best protect the skin elasticity, i.e. when my lips have swelled, they crack and chap. The facial area also feels chapped. I can give you the name of Bruce Zura's personal stylist, but the question's a hard one because really, I mean, the severity of the swelling does seriously affect the skin, and while it does go back to normal, I'm sure that there are consequences. I think that probably at this point we're stuck with moisturizing, and there are products that are initially developed with help from Mayo called Vanny Cream that are really non-sensitizing and might be something to check into, and they make all range of products that might be helpful for this.
This question is there a list of doctors in different regions of the U.S. that have knowledge and experience with HAE? And in fact, to my knowledge, the best resource for that is kept by the HAE Association. So they do have a list of physicians that are actively managing or have expressed an interest and knowledge on HAE. So that's actually where I recommend people start. There are, of course, the members of the Medical Advisory Board, and we certainly know people that we've worked with or have done research with in HAE, but I actually think the association has the most extensive list for wherever you might be.
Okay, we're getting lots of questions, so we're going to try to get through as many as we can. So I'm going to combine two. Does having HAE make you more prone to other diseases? And second, are HAE patients prone to develop other autoimmune diseases like RA and Y? So actually, Dr. Frank, who's in the audience, published many years ago in the 80s a couple papers showing that HAE patients appear to be somewhat more likely to develop autoimmune or immunologic disorders, usually pretty mild. We don't fully know the answer whether it's all in the genes. I think they speculated at the time it was due to the complement activation and the effect on complement receptors. It's an area that hasn't gotten a lot of research subsequently, but it's true. There's kidney disease that we see slightly more actively in HAE patients. It does occur, luckily it tends not to be severe manifestations.
This question actually speaks to an important topic for patients with hereditary angioedema, which is, do oral contraceptions seem to increase HAE attacks? And as many of you may have experienced, actually some of the initial presentation of attacks come when people start having increased exposure to endogenous estrogens during puberty, and certainly taking exogenous or birth control estrogens would be a risk factor for increasing the severity of HAE.
So this question says, I have small nodules that range in size from pea size to marble size. The nodules are very tender, and my doctor says these are from HAE possibly. Are these common, and what are they? Well, of course, I can't tell you what they are. I don't know, but I will say I've not seen nodular skin lesions as a complication of HAE. Typically, if they're tender like that, I might be concerned about vasculitis because of what Dr. Zura said about autoimmune issues, or they could be infectious. So those sorts of things, I think it's unlikely that's related to HAE, and I would probably work that up as a tender skin nodule, which requires an exam and possibly a biopsy.
So is there any data to suggest that symptoms decrease as one gets older? This gets asked a lot, and you'll find it in the literature. My personal we don't really know the answer. My personal feeling is that the disease really doesn't get better as you get older, but it gets better as your stress level decreases. And many times when people have finished raising their children and meeting their financial responsibilities, they seem to do better. There's always exceptions. Women, for instance, who are going through menopause and go on estrogen-containing hormonal replacement therapy may get worse. If you develop hypertension and somebody inappropriately puts you on an ACE inhibitor, could make it worse. I actually think that if you held everything else constant, the disease, once it starts, basically doesn't get better spontaneously with age.
And in a shameless plug for the registry, we are gathering this data to try, Janet's nodding, to try and answer this question, because I really don't think it's well known on a factual basis. This is a very softball question. When do they think there's going to come out with a one you take orally? Meaning, I think something like what BioCryst has in their books, and I think they're hoping soon.
This question is, do you know the percentage of people with only intestinal HAE attacks? So that's the first part of the question. So, we know that over 90% of patients have at some point intestinal HAE attacks, but most of those people, the vast majority, will also have skin swelling at some point also. So the people that purely have GI symptomatology or attacks is very small. I think I have seen a couple of those patients, but the literature would suggest that it's quite uncommon for that to be the only manifestation of the condition. The second part of the question is also the percentage of death in these patients due to developing septicemia, which is bacteria in the bloodstream. So in fact, with abdominal attacks, the most serious complication from those usually is hypotension, meaning there's so much leakage of fluid into the intestinal tract that their blood pressure will drop very low. And there have been cases of what we call hypotensive shock, where you run the risk of dying because you don't have enough fluid in your blood vessels anymore. I'm not aware that bacterial infection due to abdominal attacks is an issue. That's why in the old days when we couldn't treat these attacks, we would give people IV fluids and try to control the pain because they'd be losing a lot of fluid in their intestines. And finally, at what age should children be tested for HAE? So this is a question that comes up a lot. We know that up until about 12 months of age, that the levels in babies are not going to be sort of reaching a normal level yet. So we usually recommend waiting until after the age of 1 to get an accurate blood test for HAE.
There's a related question right there.
Related question. Is diarrhea common with the abdominal attacks, and does HAE cause constipation? So diarrhea is in fact common. Nausea and vomiting may be slightly more common than diarrhea, but all of those things happen with abdominal HAE attacks. So the answer is yes. And does it cause constipation? I've not seen that so much, and I don't think that's a major symptom, although, of course, in the midst of an attack, when the bowel is swelling, some people do have obstructive issues. So you can either get diarrhea or nothing moving through at all, which is why you get nausea and vomiting. But in terms of chronic constipation, I don't think that's a known complication.
Again, in a shameless plug for the registry, we are asking a flip side of that, which is, does constipation potentially induce an attack?
She is shameless. So my question, DX2930, how long could it take for a nurse to respond to get to you? Are there limitations to the type of episode? Can insurance deny this, or is insurance not a part? What if you're traveling? Working with Walgreen, the nurses have, it depends where you are in the country, that in general, they're able to get to patients rather quickly, often within an hour. Some places it seems to take longer than others, but it's been a successful program. There is no real limitation to the type of attack. As far as we know, all of the acute treatments work for all types of attacks. And I think that insurance issues, there may be barriers, but those barriers are meant to be knocked down. And it's part of our responsibility as physicians, if we're treating you, to help you get access. Everybody needs on-demand therapy. Traveling is a little bit more difficult because you can't self-administer the Kalbitor. And often, though, if you know where you're going to go, you can arrange somebody to be aware of you in advance.
Bruce,
What
I
drug
think they're
were they asking about?
2930.
DX2930?
Yes.
That's the investigational monoclonal?
That's every 2 week for prophylaxis.
Yeah.
Oh, I'm sorry.
But it's not
2930.
available. Not
How long
available.
could it
That's
take?
the monoclonal.
Whoa.
Yeah.
Okay, I just saw a Dyax.
Dr.
Sorry about that.
Zura
I
was
take back
very
everything I said.
eloquently answering a different question.
So DX2930 is going to be, we hope, administered every 2 weeks or once a month, and we hope that it's going to be self-administered just through a very simple subcutaneous injection. So it'll be something you could do yourself if everything goes as planned. And I think the answers to the insurance stay the same. And in terms of traveling, prophylaxis will long-term like this will make traveling very easy. I'm sorry about that.
So just to be clear, that it's an investigational drug, and we have to do those clinical trials before we're going to know the real answers to those questions. DX2930.
Doesn't have a regular
real name yet.
It's
Okay. So this question is, LASIK eye procedure potentially cause an attack? So I'm not sure directly, because there's not like pressure, necessarily trauma, but from this, unlike having an attack of HAE, I can have some personal experience. I decided to have both my eyes done at once, and they like take your cornea off, and they say, now don't move, and you're looking up, and you just see the fractals. It's just colors like a kaleidoscope. So in the if it were me category and I was going to have this and I had HAE, perhaps the stress of somebody saying, now, don't move, I would take prophylactic treatment.
This question is, can a patient with type 3 become resistant to C1 inhibitor therapy? So difficult question, because we don't actually know, we don't have studies to show how effective C1 inhibitor infusions are for HAE with normal C1 inhibitor or type 3. And in fact, I've been talking with several people about this. There's no great reason to think that should work because the protein is there, and as far as we know, it's working in this condition. That said, is literature, and I've had anecdotal experience that it does help some of these patients, and so it is something that can be tried. Empirically, we say just try because we need to do something in patients with so-called type 3 HAE. Again, based on the literature and based on my experience, the response is variable, meaning in some people it seems to work quite well, in other people it doesn't work at all. The same could be said over time, that some people seem to have a good response and then it's variable over time. So I'm not answering the question because I don't know the answer, but I would say that the response in that condition to C1 inhibitor is highly variable, and it would not surprise me if there was some change with that over time.
I'd like to add a little something to that, and that is particularly type 3 patients who have a port and who are getting frequent C1 inhibitor. The danger of thrombosis is real, in that C1 inhibitor controls both the clotting pathway and the so-called fibrinolysis pathway, which dissolves clots. And some people, in my experience, have developed clots with type 3 on C1 inhibitor.
Agree, thanks.
And so this wasn't going to be the next question, but one card says port recommended. Answer from, I think, all three of us up here would be no, no, and no. Am I correct?
No.
If you have to have a port and you have no alternative, then you'll do it. But if there's any alternative, we don't recommend ports. So I had actually questions about diagnosis, age of diagnosis again, so you don't have to wait into puberty. No, by 1 year we should be able to diagnose you. In terms of what tests for family members, worrying could you be missing it, it depends on what type of HAE we're dealing with. For type 1, you can get a C4 and a C1 inhibitor level, and that will be good enough. For type 2, you might have, if you really want to be sure, you might have to get a chromogenic C1 inhibitor function to be absolutely sure. And the final related question is, what's the relationship between C1 inhibitor levels and severity? As I pointed out, that's really still being argued about. C1 inhibitor function is measured commercially by its ability to inhibit C1s-bar, which is a complement protease. That's not the same as what causes the angioedema, which is kallikrein. And right now, none of the functional assays measure the ability of C1 inhibitor to inhibit kallikrein. And perhaps the correlation would get better if we develop the test to do that. And some people are looking into that.
This question is, why is bone marrow transplant not an option if it cured our patient, even though the transplant was for other reasons? Much of medicine, in terms of what we offer as a therapy, is guided by what you'd call the risk-benefit ratio. And at this juncture, with particularly the therapies that we have available, the risk of going through a bone marrow transplant, even though potentially with coming out on the far side with a cure, the dark side is far too dark, and many people die. Going through bone marrow transplantation is often a experience that people will tell you, looking back, they're not sure they would even do it again. And so I think that our current efforts to continue to look at research that is focused on gene repair, as well as those issues that can increase the expression of viable C1 inhibitors, such as in type 1 patients, looks much more promising.
Here's the question. If someone has HAE and the brain swells, does the symptom of brain swelling cause coma-like symptoms or no blood flow seen in a brain scan with contrast? So I'll ask my colleagues to chime in, but my opinion about brain swelling with HAE is that it's, I'm not sure it happens. You will find in the medical literature a few reports of brain swelling, but there, to my knowledge, has never been a fully documented case of HAE-related brain swelling proven by CT scan or MRI. And most of what you get in the literature are reports of people having headaches or feeling what's brain fog. Their thinking isn't clear. Brain swelling, as you can imagine, is devastating. It actually will kill people because there's not much room in your head for swelling to take place, and you actually herniate your brain stem, which is fatal. That's why things like strokes are treated very aggressively with surgery often. So the brain doesn't have the capability of swelling without it being absolutely devastating, and that's why I think, in my opinion, if it happens, it's extraordinarily unusual, and I've never seen a documented case of that. I don't think the brain is an organ that's largely affected by HAE. I don't know if you guys disagree.
I'm not sure. And I think at the first international conference, there was one of the patients that gave testimony to having episodes that sounded as though it could have been from brain swelling. And there are some interesting bits of research from trauma to the brain that have proven to be kinin-mediated. And so I think we need to keep a bit of an open mind at this juncture.
I think we have to find out. Okay, let me, before I answer the question I was going to, I got one that relates to a question we just answered. I have a port, love it, and it changed my life. That said, should I, on occasion, switch back to hand-arm? Why the collective no to ports? So we didn't amplify that. The reason that it's the medicine that's helping you, not the port, right? The port is a mechanism to get the medicine in. The reason we're so negative about it is, as Dr. Frank mentioned, that ports are time bombs in a way for having complications. Thrombosis, meaning clots, or infection, both of which can be devastating. And if you keep a port long enough, the chance that something bad that's going to happen is very high and very real. So as we try to protect our patients and keep them healthy by putting a port in, we know that they're taking a risk that we wish that they wouldn't take. Now, I think, because this is asked again, the hematologists who treat hemophilia are far ahead of allergists. They give blood products all the time, and what they've learned is you have to be very careful with veins, treat your veins like they're gold, and protect them at all costs. And so both the nurses, physicians, and patients are very careful with veins, and if you can do that, your veins should be able to last you for your life, and we think that that's associated with less risk than ports. Do either of you want to expand beyond that?
Again, I think that what we're hearing in terms of emerging therapies also, if people are from traumas in the past having trouble with their veins, to try and just nurse them along until some of these other trials can start, because I think we're very close to having alternatives.
Okay, so let me answer the question. BioCris product blocks kallikrein as a prophylactic treatment. What are the side effects of kallikrein being constantly inhibited? In a normal person, what role does kallikrein play in the immune system? This is also relevant to Dyax in their new long-term prophylactic kallikrein inhibitor, so I think it's important to just amplify on this. And the honest answer is we don't know for sure. But what we do know is that there are people walking around out there who have something called Fletcher factor deficiency, which is kallikrein. And they have a genetic lack of kallikrein. And we have animals in which kallikrein has been knocked out genetically. And in both the mice and in the human beings who lack kallikrein, every way they've been looked at, they seem to be entirely normal. So we feel very optimistic that these strategies will be well tolerated. Kallikreine's involved in a inflammatory response system downstream from the contact system. And I would guess that in the past, when we didn't have antibiotics in modern medicine, having a robust, fully functioning inflammatory response was more important than it is for a modern society where we can tolerate inhibiting kallikrein. So my expectation is that it will be safe.
This is what is the correlation between exhaustion and an HAE attack? And this, again, gets at the issue of prodromal symptoms. And I think that, again, we're trying to, not to be shameless, but gather this information in the registry. And I think that some of the questions that were asked today that we're going to look at from your responses and see what the correlation is. So this will be an answer that will be upcoming. But I think many people report a prodrome of fatigue and onset of an attack.
Here's two cards that are related. So any relation between HAE/SYNRISE and cancer. I was diagnosed at the age of 27 with thyroid cancer and was told it was very rare to have it at such an early age. And the other question is, do HAE patients run a higher risk of getting cancer? So to my knowledge, there's no link between hereditary angioedema and an increased risk of cancer, including thyroid cancer. And I guess I would just add in here that as I've talked with some of you, certainly there are a lot of complications that can be related to HAE. That said, I do see a lot of physicians, I'll call it, blaming everything on HAE, and that's simply not true either. You're allowed to have other medical problems, coincidentally. So, but no cancer, or sorry, no link between HAE and cancer from research.
Okay, I have a 2-year-old son who has been diagnosed with HAE, but has not had any symptoms. What can we do now for him? Are there any meds for him? Do we just wait until he shows signs? This is a question I think bothers a lot of people. It's wonderful that you know that he has HAE. So in fact, I guess my feeling is watchful waiting. You know he has the disease. You won't let him start to have a bad throat attack without getting him to the doctor quickly. If he starts having a lot of abdominal pain, you'll know what to make of it. Now, the good news is usually children have less severe disease before puberty than after puberty their disease gets worse. So I think that our approach is typically, as I said, watchful waiting. If you need to treat him, the treatment options right now are limited. We generally would go with C1 inhibitor, which is a normal blood protein, and we think is perfectly safe in children. It's not that the other medicines aren't safe. It's that, as I think Dr. Rydell said earlier, we don't yet have evidence that they're safe. Where some of them are doing pediatric studies, we'd love to get that medicine and make these other medications available to them. We do try to avoid androgens in children, and if we run out of other options, we can use things like Amicar or epsilon aminocaproic acid for them.
Okay, I'm trying to multitask like Dr. Zura here, so I have two questions that pertain to treatment. One is, should we use our C1 inhibitor meds for even small, less painful swelling? And can we become immune to our meds if used too frequently? And I think that one of the emphasis with both the keynote speakers is that really early treatment makes the most sense if you're having an attack of swelling. And I think that it is no longer the case that an attack should be considered as trivial. We're trying to normalize lives with available therapy. And so I would encourage people, if you think you're having an attack that's going to affect you, use your medicine and use it early. As best I'm aware, there's not a significant risk of using the medicine as causing what they'd call tachyphylaxis or getting used to the medicine and having it no longer work for you. So I don't think that it needs to be husbanded and not used for fear that it won't work if you use it on a regular basis. The other question is, does one need Firazyr if you already used Kalbitor and not having a laryngeal attack? Again, I think that Dr. Riddell spoke to the effectiveness of all of the novel therapies in terms of relieving an attack as well as the ability to prevent an attack. So certainly if you have an effective treatment like Kalbitor, there's no reason that you would need to use Firazyr or Icatibant on top of them. And then the follow-up, same question, do we use them together or separate? Since Firazyr is bradykinin antagonist and Kalbitor is kallikrein-based, do we ever use just one or the other? And again, with the trials of the on-demand treatments, Kalbitor, Icatibant, Berinert, 3 different drugs working on different areas of these pathways that ultimately cause the swelling, all of them work in terms of relieving the attack. They're just working at different points along the cascade. So it's really your availability and your preference in terms of which one you choose to use, but you don't need to use, you know, multiple for the same attack. It should also be mentioned, and it came up in our questions to the audience response, people that have Cinryze, you know, could you use that if you had an acute attack? And the answer would be yes. It did not get FDA approval for this, but did show efficacy in the same way that Berinert showed efficacy in terms of relieving an acute attack.
Is there any data comparing weather to attack triggers, so pressure changes or temperature changes? So there has been at least one study that looked at this. It tried to look at barometric changes to see if that coincided with a group of HAE patients reporting attacks. That study did not find that that was a reliable trigger, at least in the group that was studied, and that was in on the East Coast in the New Jersey area. So other than that, I'm not sure it's been studied extensively, but so far that has not borne out as a reliable trigger in populations. Studied in the scientific registry.
Yes, it's in the registry.
Thank you for that shameless plug. My question is, I was diagnosed with C1 inhibitor deficiency last year. At the same time, they diagnosed me with a B-cell lymphoma. Is this common or rare? So this is a case of acquired C1 inhibitor deficiency, and people typically acquire C1 inhibitor deficiency rather than being born with the deficiency like an HAE due to one of 2 causes. Either they have an underlying disease, and frankly, these types of lymphoid cancers are the most common underlying disease we see, although there's a whole range of diseases that can be associated, or they have an autoantibody that recognizes C1 inhibitor and destroys the C1 inhibitor, or they can have both. So the answer is acquired C1 inhibitor deficiencies rather rare, but if you do see somebody with it, I personally always work them up for an underlying lymphoma, including I do bone marrow biopsy and aspirate because I really want to make sure you don't have an underlying lymphoreticular malignancy. So it's not rare in the rare patient who has acquired deficiency.
So these are kind of related questions. If you have been on danazol for many years, is there a process to get yourself off this medication and then transition to one of the more current options? And I think that that this is an important question. We used to only have things like danazol, but as we've seen from the question response, it looks like at least 3/4 of the people in the room now have access to the new therapies. And I would say if your physician has not been proactive in trying to get you off danazol, or at least reduce the dose of danazol and get you on one of the novel therapies, that you contact the HAEA to find resources that would link you with the help that you should be having made available to you. Again, as you know, danazol is fraught with the possibility of long-term and very serious side effects that should be monitored if you're on that drug. And then the related question is, my doctor keeps stressing that I am only to use Firazyr for severe stomach attacks or a throat attack due to how much it costs. I'm hearing others say to use it for any attack. What is your opinion? If we had an audience response, we could say yes. But I think that this is another burden that is placed on people with HAE. Your physician should not be throwing in your face the cost of these therapies. And I actually remind my patients that they should bring this up to the organizational complaint area. We have a member services where I work. If you are being put in a position where cost is being laid upon you as something that makes you feel uncomfortable when you're getting the therapy that is meant for you to use.
So this is a related question that I'm going to do an audible and just answer this one now. Why are the treatments so expensive in the U.S., which I think is a very fair question. The reality of developing treatments for so-called orphan conditions, so conditions that there aren't a lot of people that have them, and we think for HAE there's probably less than 10,000 people in the United States that have this condition. The business side of that is that the research and development that these companies have to do is the same regardless of whether they treat 10,000 people or whether they treat 5 million people. And so unfortunately what happens is that those costs get spread over the people that end up paying for the drug. So if you do the math, it costs the same to develop the drug. It's going to cost much more for each dose of that drug if you have very few people actually using it. So I hope that made sense. But basically, it's very expensive to develop drugs for very small groups of patients. The U.S. government actually put a law into effect, or a policy into effect, called the Orphan Drug Act, which actually did get companies at least interested in doing this kind of work, because otherwise they would only ever develop blockbuster drugs that would treat millions of people. It's the only way they can make their business model work. So the government did come in and have some incentives, and that's why, in part, we've seen companies in these spaces, not just for HAE, but lots of other rare conditions. But that's exactly the math that's behind the cost for these drugs. And I don't like it any better than you do, but that's the reality, the sort of business reality that we live with. And the last comment I'll make is that this person also wrote in quotes that the research overseas costs less. That may be true. It probably is true. Unfortunately, the FDA generally does not accept studies that are done in other countries for drugs. They have to study the drug in the United States on the U.S. population that's affected. So while it might be cheaper to do this overseas, ultimately for a company to have a drug licensed in the United States, they have to do those studies here in our country. So that, I hope that answers that.
Okay, so a question. Are there any ongoing or planned studies specifically on HAE with normal C1 inhibitor? Will the new HAE Center in San Diego be conducting such studies on this subpopulation in lab and clinical settings? How big a clinical problem do you think undiagnosed HAE is, perhaps who are HAE type 3 or with normal C1 inhibitor? I think this is a question that bothers many of you. because there hasn't been a lot done. And it's no longer because of lack of interest. So I think that the answer is yes, there are studies being planned, people are working on this, and we certainly intend to spend a considerable amount of our time in San Diego addressing this. The problem is in part that without a good diagnostic test, and unless you can be sure that the person has HAE with normal C1 inhibitor, you can't really do effective treatment studies because you have a mixed population and you can't make conclusions. So what I expect we're going to see is first we'll make progress in trying to define people and get people we can prove have HAE with normal C1 inhibitor, and then we'll start doing therapeutic studies. And I frankly don't have any idea how big a clinical problem this is in terms of numbers of patients. At first I thought it was going to be rare. I no longer think it's going to be rare compared to HAE type 1 and type 2. It would not surprise me if this turns into a rather large problem that sort of falls over between idiopathic, non-histaminergic angioedema and HAE with normal C1 inhibitor. I didn't talk about it this morning, but the problem in HAE with normal C1 inhibitor is that while it doesn't skip generations, it can be silent, where HAE type 1 and type 2 are rarely silent, so you can miss it, which adds to the complexity. So these are issues that have to be sorted out at the genetic and biochemical level, and then we can move on and do better therapeutic trials. So I'm sorry it's not a better answer, but it's the best I can do. Okay, thank you.
Yes. These are, again, sort of related questions. How would one prevent HAE attacks through dental procedures like tooth extractions, fillings, etc.? So this gets at what we would refer to as short-term prophylaxis, so something you can do in advance of an anticipated trigger. And there are a variety of options. Certainly, you know, it has been shown that our available attenuated androgens used in advance of a procedure do reduce the risk. I think that would probably not be very high up on the list right now. Fresh frozen plasma, that of course has been available, as many of you know, for a long time, is effective if used in advance of these procedures. But again, in the if I were you category, I would want to have, if it were a significant dental procedure, I'd probably want to have C1 inhibitor infused prior to the procedure as prophylactic therapy. And I'd probably bring an extra dose of an on-demand effective treatment to have available just in case. And then the related question is, what is the medication given for prophylaxis, surgeries, dentists, etc.? But this question is confounded by the fact that the questionnaire has, again, C1 inhibitor normal or type 3 HAE, and wanted to know what tests could be done and what test does one order for this disorder. And I think Bruce just spoke to that, and unfortunately we don't have that test, but one of the things that's been discussed is at least to try and develop a test that would tell us if the mediator of swelling is kinin, as we suspect, as a starting point for at least directing what therapies might be effective in at least that subgroup of patients.
Why don't you do this one at the same time? It's related.
My daughter has tested positive for HAE type 2. She has not had any issues to date, but needs dental work done. They want to infuse her first. Can infusing for precautions trigger an attack to start? Not that has ever been reported. And again, to err on the side of caution is another fundamental of medicine. And if it's a significant potentially traumatic event, one could argue that it would be reasonable to take the step to prevent, and that wouldn't be, I think the concern here is borrowing trouble, that by treating one is engendering a greater likelihood of having an attack.
So I'll rattle off a few here that are all closely related about genetics. So if I do not have HAE, can my children still acquire HAE if it's in my immediate family, a sibling and father? So the general answer to that is no. I'm going to assume this is HAE due to C1 inhibitor deficiency. And as we understand that, that is what's called autosomal dominant. It's passed down from generation to generation and does not skip generations, such that if this person has been tested and does not have HAE, then there should be no chance of the child having HAE. It stops there in that part of the family tree. It does not get passed on. So that's that. This one says, you said there are 400 gene mutations, so does each family have the same mutation in the same spot in their genes, or can they have different areas of mutation within their family? So again, for C1 inhibitor deficient HAE types 1 and 2, that genetic defect, that mutation is passed down, the same mutation from generation to generation, so from parent to child. And you can actually do the genotyping and show that it's the same within that family. So even though there are hundreds of different mutations within a family, as far as we know, it's the same one over and over. Now, that's not to say that the spontaneous mutations happen, these de novo mutations, and that's why we keep learning of new, that's why the number keeps growing, because we keep finding different mutations in different families. But within a family, as it's passed down, it stays consistent, the same mutation. And that actually is useful as we get more advanced with genetics. There are families that have tested embryos ahead of time to see if that mutation is there, because you know exactly what you're looking for. In one family, can there be 2 different types of HAE? Again, I never say never in medicine, but generally I would say no. It's consistent. So if your father or mother had type 1 and you inherited the gene, you're going to get type 1. And we don't see mixing and matching of different types. And then finally, I have type 3 HAE, and I was told my son would not have the chance. He's now had 3 attacks. Is this normal or heard of? So this is a major difference between type 1 and 2 and then type 3 or HAE with normal C1 inhibitor, in that it does appear that there can be, well, 2 things. That males can have it, although it's rare. And as Dr. Zura said earlier, it's been described that the males in type 3 can be silent carriers of this. They may not have symptoms and then have a daughter that ends up having symptoms. But it's not unheard of, and in fact is clearly in the literature, that males can develop type 3 symptoms, HAE with normal C1 inhibitor symptoms, although they only account for about 5% of all the reported cases. So it's heavily a female affected population.
Okay, next question. If estrogen is a trigger in women, does it continue to cause HAE symptoms? Could an increase in estrogen level in men be a trigger, and could some of the new cancer drugs for breast cancer that block estrogen production help HAE patients? So estrogens, we're really trying to learn more about how they worsen angioedema. We know for sure that they increase levels of factor 12. We suspect that they have effects on bradykinin receptors, and there's reason to believe that estrogens also decrease the level of endopeptidases called kininases, and these are enzymes that break down bradykinin, so that if you decrease their level, the bradykinin has a greater effect. So the answer to should a woman with HAE take estrogens, the answer is unless she tolerates it if she's doing very well and taking estrogen, fine, it might not bother her. But if you're continuing to have swelling, it would be the first thing that I would recommend is that you stop the estrogen-containing medicine. I think there's a lot of concern in general about the phytoestrogens that we are getting environmental exposure to, including men. It would not surprise me if that does contribute. I think that it's something we have to keep our eyes on and look at carefully. And in terms of the estrogen blockers used for breast cancer, the problem, as I understand it there, is that the side effect profile would make them somewhat problematic just using them in patients who don't have cancer. So avoiding estrogens, using pure progesterone alone has been shown to be tolerated, in some cases to be beneficial. It actually helps women with hereditary angioedema. And in France, they have strong anti-gonadotropin medicines which suppress the production of estrogens, and they've gotten some very good results with using those.
Just real quick, this next question I had was, you mentioned hormone replacement therapy in the pill. Is progesterone only pill okay? And so just in case you didn't catch it, generally yes, and in some women with HAE, actually beneficial.
I guess we're still on hormones. So I should mention that there's some literature for the people with normal C1 inhibitor that these progesterones and anti-gonadotropins have also shown significant promise in terms of therapy. So this questioner is very nervous about the effects of menopause that will be coming, and is there anything that can be done early so there won't be problems then? Every woman who is on the verge or has gone through menopause would like to have something that would have affected menopause. But I think that the questioner is speaking more about the HAE. The same sort of treatments would apply during menopause as at any other point. One of the things of interest that we're collecting in the database is to look at the effect of menopause, because what we don't know is whether the decrement in hormone levels will necessarily lead to a decrement in the frequency of swelling, or whether in perimenopause fluctuating levels will enhance the level of swelling. So these are questions that we're looking to you actually to answer.
Can type 1 and type 2 HAE develop thrombosis with C1 inhibitor? So the answer to that is yes. The risk of that with the C1 inhibitor products we believe is low, but it has been reported. Most of the cases of thrombosis that have developed with that treatment have either been at very high doses or in patients that have other factors that contribute to that. So ports being one, or other what we call coagulation issues like antibodies against the coagulation factors that we know are risk factors for clots. Nevertheless, it has been reported in type 1 and type 2 patients, and it's something we have to be very watchful for, I think, as a serious complication of the treatment.
Okay, I'm going to take two somewhat related questions. We only have 10.5 minutes left. We have so many cards left up here. What does it take to make it less than 9.1 years to be diagnosed? That is the million-dollar question in my mind. And I'll give you a cynical answer. I've given up on doctors because I've been speaking to them for many decades now about this, and I can't seem to make a big difference. And so I've turned my attention to talking to you, to patients, and you heard Janet and Tony asking you earlier today, talk to your family, reach out, get people to see the doctor. I actually think that through the HAEA website and patient awareness and going to doctors who are willing to listen to you, that's the way we're going to reduce it. I wish I were wrong, and I hope I'm wrong, but that's my answer to that. And a related question, my local allergist immunologist fired me after 5 years because I refused fresh frozen plasma in the hospital after the recommendation from my HAE specialist precautioned against it as it could possibly make my attack worse. Did I have the right to refuse a blood product without being fired as a patient? I think you have every right to be involved in your own treatment. I think that's absolutely fundamental to how we organized healthcare, that you are responsible for yourself and we should work with you. And I frankly agree with your saying that FFP is no longer the standard of care when you have other treatments available. And the only thing I can say is there's a lot of doctors out there, and you can find yourself a more responsive doctor, I hope. I think that a lot of us, certainly everybody in the medical advisory board, would be willing to, if it just takes education, would be willing to call your doctor on the phone and just talk with him or her and say, listen, here's how we think it should be done, if that were to help.
And again, I think the HAEA is your best alliance and resource, and this is where, again, the information's there to help you. And I think that the questioner was fortunate to be fired by that doctor, because I think it exemplifies the arrogance of somebody when you are bringing to their attention something that is a real issue that both Bruce and I have personally witnessed, which was a horrific worsening of an attack with FFP.
Twice.
Yes. That you had every right to refuse, and the doctor should have listened. So these two questions are definitely related. And I guess since we are now the three doctors know, what specifically can be done to treat your veins as gold? How do you protect your veins? I think these are excellent questions. And I think that one of the things that the HAEA has been very staunch about is for you to be your own advocates in terms of how you approach medical care, how you accept medical care. And I think in this instance, we've all had the experience of going and having our blood drawn, and you get somebody who's bad, meaning that they pierce your vein, you see something that looks like the shape of Mount Shasta coming up, and that we've been sent for tests, and then somebody thinks of another test and sends us for more tests. And, so we're having multiple punctures. So I think that, as patients, you need to be, again, advocating for this is a critical issue for you. If you go to have your blood drawn, you need to tell them that it is important that they have their most excellent phlebotomist do that blood draw for you. If the doctor is recommending that you have blood tests, ask if there are any other anticipated blood tests, and can you wait if you see multiple doctors to go for your blood tests until you've found out all of the blood tests that everybody needs for you, so you can have them done with a single puncture. And the less that somebody messes with your veins, the better your veins will stay. And so I think that making sure, in the same way that you'd want to look for a good doctor, a good dentist, you need to know who's good in terms of, if you're going to get infusions of your product, who's the best at that. If you're going to get blood taken for a different reason, who's the best at that. And don't settle for less.
So I'm going to quickly do this, and then one other one. This is in the vein of what Bruce just said earlier. So the question was a little bit. Did you catch that? That was good, huh? I like it. What are the expert physicians doing to educate other healthcare professionals about HAE? And so I just want to provide a counterpoint. I'm maybe a little less cynical and jaded than Dr. Zura on this, in that I know some of my colleagues spend as much time as we can talking to doctors about this condition. I accept, as my schedule allows, almost any invitation that I get from doctors groups to speak about HAE, because I do think it's still important to make that effort. And so I think we have collectively saturated, I think, the allergy community to some extent. And it was actually nice to see that most of you are taking care of biologists, not because I think we're necessarily smarter or better, but because I think that's the most educated subspecialty at the moment with regard to HAE. But I do think gastroenterologists are seeing people with this, and I think the emergency department, which is a very tough audience, are seeing this. So I do think I spend a lot of time doing programs and more aimed at other specialties, primary care, pediatricians, to try to at least put this in their head, because the hardest part of the diagnosis is thinking of it. Once you think of it, it's easy to send the blood work. And so if we can just flip that switch that they think, I saw something about this, I'm going to send the test, we can hopefully shave that diagnosis time down. So we're trying. I'm trying. The question I was going to answer as well is, I've considered taking anti-anxiety medicine. Will it help? So I joke with my patients a little bit about this. We know anxiety or psychological stress is a trigger for many patients, and so I write them a prescription for a stress-free life, and so easy, right? You won't have any more problems. We can't do that. We all have stress, and we have to cope with it. So I do think stress reduction in whatever mechanism works for you is worth thinking about, if that's a trigger for you. That said, I'm not a fan personally of chronic anti-anxiety medications. It's not something I prescribe as a treatment. I'm more of a fan of exercise and yoga and things that I think are easier and safer to do in the long run. And the last comment I'll make, I'm not a proponent of it, but I come from California, where medical marijuana has been in use for